start recording as well. Okay, that may click off halfway through, as it has been prone to do. So, okay, hi everybody. Yeah, as Charlotte said, I'm Suzanne, the current chair of AGILE. Obviously a physio by background, but I've worked in research for numerous years now. So still not an expert on critical appraisal. I will do a disclaimer in a second. I'm just going to share my screen. I've got a few slides. And if somebody can let me know that you can see that. Yeah, thanks, Sarah. Okay, so yeah, so welcome to the Journal Club. Let me set up the, sorry, proper slideshow. There we go. Okay. So yes, my disclaimer is what I'm going to say are purely my own views, opinions, thoughts, interpretations of the paper. You may totally disagree, which is great. That's what we're all here for. It is a journal club. It's about us all sharing our thoughts. When we get to the stats part, I'm not a statistician. I can do my best to explain any bits if people have questions, but yeah, I may not be able to answer your question, but I might be able to point you in the direction of somebody who can. As Charlotte has said, this is the paper that we're going to have a look at, and we're going to use the CASP critical appraisal tool for randomized controlled trials. So all the details of that are there. So the CASP tool is basically asking for overarching questions. Is the study design valid for an RCT? Was the study methodologically sound? What are the results, and will they actually help you locally? So they're the big 4 questions that we're trying to answer. Okay. So before we start, over to you. This is just to get a feel of what you think of the paper, having read it, having looked through it. So I'm going to, this is where it all gets fiddly, go to Mentimeter. If you've all logged into the Mentimeter, and you should hopefully be able to see the first question, which is, what were your general impressions of the paper? So if you'd like to just jot down any words that you thought that sprung to mind, and then we'll share that. That will all come up as a word cloud, and I'll share that in a second. So have you all been able to log in okay to Mentimeter? Silence. You start entering some. Is it working?
Suzanne, my Mentimeter is taking me straight to the first question.
Yeah, that's fine.
Rather than putting, so it's asking me, I don't know if I'm the only one, if you're not getting anything up. It's asking me, did the study address a clearly focused question?
Sorry, for some reason it's gone wrong on the first one. That's fine. We'll go straight to that one then. Okay. Right, let me come back to my slides. So has everyone put their opinion in, and whether they think the study did address a clearly focused question? Let me get my bits of paper ready. Everyone voted who wants to? Okay, so if I share that. So most people, can everyone see that? Yeah, so most people think that the study did address a clearly focused question. Oh, yeah, a few people think they're not quite sure, and one person has said no. Anybody like to comment on why they think it might not be a clearly focused question? I've said I think it is, using the PICO model, which I shall come back to. Bear with me. So, okay, if you can see the screen now. So I've filled in the PICO. So they talk about frail older medical patients in the acute setting. That's the population that they're wanting to target. Their intervention is usual care plus the augmented prescribed exercise program. The comparator, so the control arm basically, is the usual care plus a sham exercise program. And then the outcomes that they've outlined, length of stay is the primary outcome, and then these are the bits and pieces for secondary outcomes. Is that what everybody thought? I can't see the chat now, so if anybody's got anything to add to that, or why they thought they couldn't tell that it was a clearly focused question? I will say that I think they talk about frailty in their population, but that's not particularly a focus of the paper. When, I mean, they do measure frailty using a score I'd never heard of. So that was a little bit, not dubious, but that was something that I picked up on. The other thing that I picked up on was, why did they bother with a sham? Why did they bother with the breathing and the stretching exercises? Why didn't they just compare it with usual care? I don't know what anybody else's thoughts are on that. But ultimately, they have explained their PICO model. So I think they have asked a clearly focused question. And they do say that their aim is to measure the effectiveness of this augmented prescribed exercise program on frail older medical patients in the acute setting and on the outcomes. So I would say personally that I think that has asked a focused, clearly focused question. Okay, any thoughts on that? Any questions so far? No. Okay, so was the assignment of participants to interventions randomized? Back to the poll. Sorry for all the to in and fro in. Okay, over to you. Was the assignment of participants to interventions randomized? I like this. Oh, you can't see it, sorry. I was just watching it myself. Any more for any more? Ooh, yeah. Okay, that seems to be about the numbers that we're getting. So again, majority of people think yes, a few think they can't tell, and one has said no. Okay. Again, if anyone's happy to share their thoughts on what they think, or why they think that is. No? Okay. So I think that assignment of participants to interventions was randomized. It may not be where you think it's going to be in the paper, so you may have to hunt around to find that information. That's the thing, is you have to might have to go back and forward to actually find it. But if you look on page 4 of the paper under procedure for data collection, which is probably a weird place to put it. Normally there should be a heading with randomization or something like that. It does say that the patients were randomly allocated to the intervention or control group using concealed allocation, and a blinded research assistant assigned and recorded the patients using a computer generated randomization sequence in varying block size. So I think we can safely say that they were randomized using a concealed method. It wasn't just you look at the draw, but it was done by a computer program. So I think we can say that they were randomly allocated. My one caveat to that is that when they were informed about their allocation, they weren't strictly told about it as such. I think they were just kind of the treatment kind of just started without them being told specifically. That's how I interpret that anyway, when they said that while patients were informed that they would be allocated to either the APEP or the control group, they were neither explicitly informed nor encouraged to ask about their allocation. So that kind of gives them a little bit of blinding, but that I've never heard that before in a trial, that they've not specifically been told. So which leads us on to another question in a second, but does that make sense? Is everyone clear with how that came to that conclusion about randomization? Yeah, any questions?
I think it was, Suzanne. I think I found it, I was hunting for it a bit. I think the comments in the chat is just, it wasn't easy to find. No. And you did find yourself hunting around for it a bit, but yeah.
Yeah, it was kind of in the wrong section. It should have been a little bit clearer. It shouldn't really be under data collection, because it's not about data collection. It's part of the methods, but they have done it. Yeah. Okay. Yeah. So, were all the participants who entered the study accounted for at its conclusion? Back to the share this again. Ooh. Over to you. Yes, no, or can't tell. Any more for any more? So we have 18 people say yes. 5 can't tell. Okay. So my thoughts, again, this is my thought, you may wish to disagree, was that a good way of knowing if they've done this is to look for their consort diagram. So every randomized controlled trial should include a consort diagram, which is basically a flow of patients through the trial. So if we look on page 6, that is a consort diagram. And it does give you an idea of who and where the participants kind of came from and went to. And they also have a good bit of text about it as well. At the start of the results section, they talk about how many patients they screened, how many patients they were eligible, how many declined, and then how many went on to be randomized, how many were then excluded and the reasons for that, and who dropped out and things like that. So I would say that you definitely know where the patients have gone through the process of the trial. And it is really important to do that. If you don't explain that and suddenly you're just reporting data on 150 patients when you had 300 at the start, well, what's happened to those other 100 and where are 150 and why have they dropped out or where have they gone or what might it be? So it is really, really important to account for all the participants. Even if they have dropped out, you just have to be honest and say that. And even if you've got less data than you intended to have, it's really important to know that. So does that make sense to everybody? So always look for the consort diagram. It should be there. If it's not, it's not abiding by the guidelines of consort, which are very much what RCTs have to be written by those guidelines. Okay. So overall, is the basic study design valid for a randomized controlled trial? So if they're based on those 3 questions, I would say yes, but with a few slightly questions about things like why did they use a sham? But we'll come on to those, I think, in a little bit more detail in a minute. The other one to say about the last question, sorry, I've just realized my notes, was the study was stopped early, but they explained why, that their pathway changed and that these patients were not discharged home anymore. They went off to a step down unit or wherever it may be. So, but they didn't just not tell us that, they told us why and the reasons why, and that was a protocol change. So a deviation. Okay, but yes, I would say it's a basic study design was valid. So therefore it's worth having a bit more of a read of it and finding out a little bit more about what they've done. Okay, so blinding, is everyone happy with blinding and what it means and why we do it? So it's really important, and you'll hear randomized controlled trials talk about being single blinded, double blinded. It's basically to try and reduce the risk of bias of people, of different biases being introduced into a trial. So if we think about these 3 questions, were the participants blind to the intervention they were given? This, I think, will be an interesting one. Let's get the poll up to see what people think. Okay, so what do you think about the participants being blind to the intervention? Interesting. Any more? So I've got a real mixture there of mainly people who can't tell, and that kind of sums up my piece of paper where I went from no to can't tell to yes, can't tell, because of that, what we just talked about, the fact that they were told they were going to have an intervention, but then they weren't specifically told which one they were getting. Doesn't mean that some of them won't know, if they were explained, if the study was explained to them in enough detail and the patients really understood, then they should realize which kind of treatment they were getting. But I think that raises another question about the actual consent and the way the trial was explained to patients. I don't know if anyone's got any thoughts on that, but from what I read, it said patients were given verbal, patients were verbally informed about the study and questions were answered. That raises some alarm bells for me, because in the next sentence, they talk about cognitive impairment being an issue. well, if you're just telling patients things verbally without any written information, how are they going to remember what they've even consenting to? So I think that kind of led on from this blinding question for me. That kind of had a knock-on effect of, well, what were they actually told? And
we have a hand up, Suzanne, as
well.
I think Sarah has something to say.
Yeah, go ahead, Sarah.
Yeah, no, I was just going to agree with you. I'm really surprised they didn't have a formal piece of paper that perhaps they either read to the patient or read out to the patient and then provided for the patient for future reference, so that we know, we would have then been able to find out exactly what they were told. And then the people actually administering the treatment as such they wouldn't have been able to deviate from that. So all of those previous things we were just talking about blinding things, we would have had a much better idea on.
Absolutely.
And of course, the other thing is then, you know, where bias might come in just because of what perhaps some of the people actually administering the treatment, whether they're, whichever group they're in, whether that would have changed the outcome at all, because the patients knew or weren't sure, or that their understanding of the of what they were doing. So I think that has quite a big impact.
Absolutely.
The other thing is Jane Manson in the chat has put about, was there information about ethics? I think she's seen something about a local ethics committee. I don't know if you want to comment.
Yeah, where was that? Can anybody find that sentence that he said about ethics? I think it was near the beginning, wasn't it?
Yeah, it's it's on the first page. No, second page, right at the very bottom.
Oh yeah,
where methods.
Yeah, the trial received ethical approval from the local clinical research ethics committee. So again, this was only done at one trust, one hospital. So I suppose they just, I don't know, whether they still should have gone for full ethics, because they were intervening on patients. So that is another issue. The consent thing, the lack of information is a real red flag to me, because I don't know how that got through an ethics committee without them giving written information, because how can you give informed consent if you've not got the thing to take away and think about? You know, you're supposed to have information to go away with and be able to read and ask questions about. So I think that definitely raised flags for me. So Christine, I can see your hands up.
Yeah, at the end of the paper, there is an ethics approval and consent to participate. And it says patients informed written consent was gained by all participants, and the next of kin gave written consent when consenting. Participants were deemed to have poor cognition, but that doesn't mean that it told them what they were actually doing.
No, it doesn't say anything.
They just agreed to what they were doing.
Yeah, they may have given them written information. We just don't know. They just haven't reported it. You'd like to hope that they did, but we just don't know. But yeah, again, that Clinical Research Ethics Committee of Cork Teaching Hospital. So that's very much in-house ethics, which is still some ethics. It's better than no ethics. But yeah, I think that may raise issues. Oh, Holly?
There we go. Hi. Am I being daft? But if that's all being adhered to, and therefore they've got all the written information, does that just make it not possible for it to be blind?
Yes.
Potentially, and then you'd be like, oh no, there's different. Right.
In exercise, in any trial of exercise, it's practically impossible to blind the participants, because they know what they're doing. They are doing the exercise.
About the person who's doing the assessing.
Yes, So that's moving on to the next question. Yeah, where the investigators blind, again, can't be, because they're delivering the intervention. So the investigators are the people actually doing it. And so the physio who's standing there doing the exercises with the person knows which exercises they're doing, so they can't be blind. But then the people doing the assessing, in this case, they were blind. So this is why it's a single blind trial. So it's only one of the groups of people who could be blinded are blind to what the intervention is. Yeah, absolutely. It's not a drug trial. We're not off. I mean, that's why I'm wondering why they bothered with the sham, because it's not they're trying to offer something, I suppose. And that may
got a thing in here about they'd started to, if people were in a mixed bay where they got a mixture, they didn't actually hide what they were doing differently.
I know, yeah,
even though
It says that, yeah, it says that there was nobody in the same bay doing the same exercise. I find that very hard to believe, after all those hundreds of people, that nobody was in the same bay of 6 beds or whatever it may be doing the same thing. Yeah, there's definitely some discrepancies, I think, there. But yeah, so so the blinding, like I said, participants, we're not really sure whether they were blind. We can't say they were definitely blinded, but we can't say they weren't. Investigators definitely weren't blinded because, well, it was just one physio doing all the intervention anyway, and she knew what she was delivering. But the people doing the assessments, they were blinded. That's what it says. Yes. Okay, so we'll skip on then to the next. What have I said here? So yeah, that's just to cover what we've just said, basically. Yeah, so the person who randomized the patients, they were blinded. They had no control over that. This is the tricky bit about whether the patients knew or not. And then, yeah, the follow-up assessments were completed by a blinded research physio. Again, it's really important, if you can blind, to do it as much as possible, because it really does help to reduce your bias. Okay, were the study groups similar at the start of the randomized controlled trial? So let me go back to this. I'll just skip on. So we've done that one. I'll just skip through the blinding ones. Okay, so what do you think? Were the study groups similar at the start of the RCT? Too many bits of paper. Ooh. Bit of thought needed about this one, possibly. Need to find the right bit. Okay. Any more? Any more? So the majority of us think yes. I ummed and ahed. I went again from yes to maybe no, but it can be a tricky one because sorry, there we go. I think the big thing is that yes, mean age differed slightly. So this is all on page 5 within the results in the second paragraph. So it said between the two groups there was a slight difference in age, but they did some statistical testing on that and it wasn't significant, and they were adjusted for age anyway within the analysis. They were able to take that into account. But the significant difference between the groups was that there was obviously a lot more women in the intervention arm than there were in the control arm. And that's kind of all they say. They do say that it was included in the multivariable analysis, and later on in the results it does say that things were adjusted for gender or sex, whichever way you want to call it these days. So they have taken it into account, but it's quite a big difference between the numbers of women in the group, so that may have an influence on, you've got to take that into consideration, I think, when you're looking at the results. If it was a trial of, I don't know, surgery that, women's anatomy was different than men's and that had an influence, you might think that had more, you might take it into consideration a bit more, but it's just to be aware of it, but at least they have said there is a difference and it is significant. But apart from that, the groups were very well matched. So you probably would say, yes, they were, the groups were very similar at the beginning, but it's open to interpretation, which is very useful answer, I'm afraid, but that I think is just something to bear in mind. Okay, any questions on that or any comments?
We've had a comment from Susan just highlighting similar to what you just said. So the majority of characteristics were similar, but more women in the intervention group, and that was very much in the article. It was identified, wasn't it, as well?
Yeah. So okay, great. Okay, apart from the experimental intervention, did each study group receive the same level of care? Were they treated equally? So let's go back to the poll. Okay, what do we think? Yeah, Okay, so majority of people think yes, some think they're not quite sure. Okay, again, I think I would say that yes, we can. If you look at these questions, the kind of considerations that they ask for. So was there a clearly defined study protocol, which there is, but again, you have to kind of read right down into that to find that. I can't even remember where I read about it, but there is a protocol because I found it and had a look at it to check, because I wanted to look at the description of the exercise interventions in a bit more detail to see if they had that. So, but you have to go looking for that within the reference list. I can't remember where it said it about the protocol. It definitely said something about there being a protocol. It might be where it's describing the interventions. See, this is what I mean. You have to keep looking forward. You know, you never read a paper just once because you'll always miss something. So, but there was a protocol. If any additional interventions were given, were they similar between the study groups? Well, they were both given usual care, so they were both given their normal physio, whatever that may be, and then just the difference in the exercise groups. But that makes me wonder why they did the sham, and I don't know if anybody's got any thoughts on that. Why not just compare usual care with the augmented exercise? Because it's not like the people in the control group weren't getting anything, because that can be unethical if you say usual care, but it actually doesn't really consist of very much, but they were getting their routine standard physio. So why bother with the sham? That's just me, just not sure whether I'd have bothered.
Suzanne, was it to help the blinding? You know, the fact that a therapist was going in to do an exercise session, you know, of a similar duration twice a week on top of usual care. But then I'm thinking the setup, you know, the typical setup on a ward is such that it's a curtain, isn't it, really?
Yeah, I agree. I think it adds that element of they're both getting something, so you may not know. But I don't know, I just felt that it was a bit, I don't know. That was just me personally, and everyone can have their thought. I just didn't think it was really necessary, because what if the sham has actually been beneficial? I know it's only breathing exercises and stretching exercises, but who's to say that it hasn't had an effect? You're not then, you don't know what you're testing then. Do you know what I mean? We're here to look at that exercise program, but if I know they've picked things that probably won't have had an effect on the outcomes that they're looking at, but you don't know that. And so they've kind of made it more complicated for themselves. That's how I felt, but please feel free to disagree.
There's another variable in there, isn't there?
Absolutely, yeah.
So that's what's muddying the water, so to speak.
Yeah, yeah.
We've had a few comments in the chat as well. We've got Helen Court says, we don't know how many in each group received physiotherapy, which was in addition to the study on a referral basis. I would have liked to know how many had additional therapy. I think it did say somewhere, which I think Rebecca's picked up on, where it says average usual care was up to 3 times a week. But it's interesting, isn't it? I would have liked to have known what the usual care constituted.
Yeah,
that's just me.
It was sorry, I dropped out a little bit there. Apologies, but yeah, I agree. It was like they said they might get 3 sessions a week, when something like that, wasn't it, from routine physio? But what? We don't know what they were getting, and yeah, so usual care for one person can be very different to another. So it has definitely muddied the water. I think the interventions are a little bit hazy as to what actually is going on, but that's just my interpretation. But in terms of, and then the last question there is, were the follow-up intervals the same? So yes, they were. So I think we can say that the groups were they were given what they were supposed to be given from what we can read, but we're just not too sure about the detail of what that is. So I've said yes, but I can understand why some people would say you can't tell. And again, that's just how you interpret it. Yeah, so both groups received usual care with additional exercises, and just what those groups were meant to be. Okay, so was the study methodologically sound? I don't know. It's my answer to that question. I don't know what everybody else feels. I'm not 100% convinced it was methodologically sound because of the issues we've talked about with the giving patients information, the type of ethics they've got, and the descriptions of the interventions. I don't know if people agree or disagree. Any thoughts?
I think I just agree with you. I've just put it in the chat, Suzanne. I just think it's a bit iffy. I think the sham treatment is a total waste of time, because actually what we want to know is, do extra interventions or different treatments change these outcomes compared to our normal? So why they're comparing it to sham treatments? I know people have put some comments in the chat about maybe reducing unconscious bias and things like that, but it would have almost been easier to do that, you know, compared to what is normal, and then take a cohort over a month and follow them, and then another cohort, and with the extra treatment on top of the normal, and see what the difference is.
I agree, Sarah. I think that it's not like I say, it's not like they weren't getting any, we're not getting any treatment. They were having their usual care. So but that's my thoughts, is that it's fine, it's sound enough, but it's got some things to bear in mind when you're then looking at the results and interpreting the results. Okay, so
the other thing is, Suzanne, Heidi's put in the chat, which I think is a really good point when you talk about the method. She's put that she wouldn't be able to duplicate the study because there's not enough detail, and I think that's a really good yardstick of how sound it is, because if you can't follow it point by point, then the age-old problem with physiotherapy trials is that the intervention is not described in enough detail for us to actually be able to take this intervention and run. I found it very interesting that it was just the lead author was the person who delivered all the interventions, and it was like, well, based on what was her evidence base for her intervention? It was very much, she obviously did strength and balance, but was it based on a Targo? Was it a PSI? Was it false? I don't know what it was based on. So, and I know it has to be individualized, but you've got to have some evidence underpinning what kind of program you're choosing. And we know that now about strength and balance, and how, the evidence needs to be there for you to get the right dose and the right, those kind of things, which they do talk about in their limitations. I know that, but we'll come on to that in a minute. So, were the effects of the intervention reported comprehensively? Here we go, fun statistic time. Let's just go to the slide. What do you all think? I haven't even ticked an answer on my piece of paper. Interesting. Yeah, any more? I think I would probably agree with the majority, but for one specific reason for me personally. Any more? Okay, majority I can't tell, but a few have said yes and one person said no. Where is it gone? Sorry. So if we look at these questions, was a power calculation undertaken? And I kind of got stuck there. That's where I started getting my hair off about it, because they kept saying that they wanted 220 people. That's what their power calculation was, and they only got 190 because they wanted to stop the trial early. But nowhere within the statistical section on page 4, where it's got all the statistical methods, the first thing you should be able to see there is what the sample size is going to be and how they came to that conclusion. And to get a power calculation, that's based on your primary outcome and what kind of difference you're looking for in that primary outcome. So that's where the statisticians do their magic. We just say at work that they just pluck a number out of the air for the sample size and the power calculation, but there is some science and maths behind it, and it's usually based on the minimal clinically important difference of an outcome measure. So let's say on a pain scale, you want people to reduce their pain scale by 1 point. That could be the minimal clinically important difference for patients, and all that kind of thing. And that is usually described within the stats section of a paper, and there's absolutely no hint of it anywhere. It just says that, I think it says somewhere based on a previous observational study, that's where they got their power calculation from. Well, I looked at that observational study and there was nothing in that about power calculations either. It was the measure, but it was a very, very small number of people. So so I got very upset about the lack of power calculation. And for me as a non-statistician, I was amazed at myself. So but
other than that, I think that they did clearly outline what measures they were going to measure, what they wanted to look at. They expressed the results. They talked about the statistical tests that they were going to do, and they did report p-values. But I just can't get past where is the power calculation because we've just no idea why they picked that number. It kind of is meaningless if you haven't got the basis of the outcome measure underneath it. Any questions on that? I may not be able to explain it any better than that, but any thoughts, any comments? No? Good. So we can move on from that one swiftly. So was the precision of the estimate of the intervention or treatment effect reported? I'm just going to say yes to that one because the only question there is were confidence intervals reported, and they were. Is everybody happy with confidence intervals, kind of? What they mean? No? Holly, I can see you shaking your head. Okay, so I will try and explain it as best I can. If I could use one of the examples, maybe. Let's see. So if you look on page 5 under the physical performance and functional independence section, so at discharge, physical performance scores were better in the intervention group than in the control group. So those in the intervention group were scoring 4.6 compared to those who were scoring 3.7. The difference was 0.88, so that's the difference between the scores. Ignore the confidence interval for a minute, but the p-value was 0.01, so that means it's a significant result. So 0.01 is less than 0.05, which is usually the level that you set your p-value at. And because the confidence intervals are above 0 and upwards, they don't contain 0. If a confidence intervals is like, say, -2 to 2, it contains 0, and that means the result can't be significant. Your p-value probably won't be a significant value. But if the confidence intervals are, as it is there, it's only just above 0 to 1.57, and the p-value is 0.01, that's a significant result. Does that make any sense to anybody? Sorry, Holly, it's not easy to get your head around. Okay, but if you look at the confidence intervals and it goes from a minus figure to a positive figure, then your result is very unlikely to be significant.
Sorry, which bit of the page?
Sorry.
Page 5, and then you were off, and I was like,
Oh, sorry, page 5, where it says physical performance and functional independence, down the bottom on the right.
Yes.
Okay, so the first sentence, at discharge, physical performance scores were better in the intervention group, 4.6, than in the control group, 3.7. Okay, and the difference that means is 0.88. Then, like I say, just ignore the 95% confidence interval for a second, and you see the p-value is 0.01.
Yes.
So that's a significant result because it's less than 0.05.
Okay.
So a p-value of less than, usually of 0.05 means that's a significant result. Okay. But the confidence interval gives you more confidence in that result because it doesn't contain 0 in between those two values. So where it says 95% CI, 0.20 to 1.57, they're both positive numbers. So they don't include 0 within that range of numbers. So that means it's a significant result. It could be that they were both minus numbers. It could be -2 to -4, and that would still be a significant result, but the other way, in terms of it would have been a negative result for the intervention. It would have been the control group were doing better.
Oh, right, yeah. Okay, then, yeah.
Sorry.
I don't know what numbers you're talking about.
Sorry. I went too fast. Sorry about that.
No, thank you.
It's something that unless you're doing every day and reading it every day, you still have to get your head around it, I think.
Yeah.
So I just hope that's made it a little bit clearer.
Definitely. It gives me half a chance of reading something and at least knowing what figures to even look at.
So it's just knowing if you see the p-value is less than 0.05, well, you'd say that's significant anyway, but then check the confidence intervals to make sure that they don't include 0. And then, that gives you more confidence. That's the whole point. They give you more confidence that your result is true, basically. If a statistician heard me saying that, I bet they'd be like, oh my God, what's she going on about? But I hope that helps.
For me, my level.
Yeah.
Thanks very much.
Good. Okay. So that's that. Yeah. So I'm just looking at the time, just going to go through some of the results. So basically their primary outcome was length of stay, and it showed that there was no significant difference between length of stay, although the people in the intervention group did have a shorter length of stay in terms of 880 nights compared to 970. If you look here now, you can see that the p-value is 0.48, so it's way above 0.05, so it's not a significant result, even though the confidence intervals are above 0. You go to the p-value first to see what the significance is, and then look at the confidence intervals. They did adjust for age and frailty. I'm not quite sure how they adjusted for frailty based on that measure, but that's another issue that we haven't really touched on. And it was still insignificant, but there was a slightly bigger effect. And then all the other things, most things were, there was no effect apart from the physical performance that we've just talked about that was significant at discharge. But then interestingly, 3 months later, they'd lost all that benefit. There's a surprise. That was my whole PhD in a nutshell, that basically once we stop intervening on them, everything goes back downhill, unfortunately. Yeah, and just there was no differences in all the other outcomes. You know, and in their discussion, I think they come up with a lot of reasons as to why they think that is, but ultimately I'm just not sure that the intervention was what it should have been, but we'll have a look at that in a second. So, do the benefits of the experimental intervention outweigh the harms and costs? I don't like this question. I don't think it's worded very well, but let's have a look. What do you think? Let me go to the... Let's go to that one. There we go. So what do you think? Do the benefits of the experimental intervention outweigh the harms and costs? Where's my piece of paper? What do we think? It's not an easy question to answer, I don't think. It might just be me. Again, a bit of a mixture. And I think I went through all answers. I went from one to the other, crossed out yes, now I've finished up with can't tell as well. So what you're looking at there is what was the size of the intervention or treatment effect, which is very difficult to tell when you haven't got a power calculation and you haven't got your sample size and those kind of things. You need those to help you understand your treatment effect. And we haven't really got that. Were harms or unintended effects reported for each study group, which they were. They did talk about the number of falls in each group, the rehospitalizations, those kind of things. And then was a cost effectiveness analysis undertaken? No, it wasn't. But does that mean that the experimental arm, did it outweigh the cost, the harms and costs? Well, I really don't know. I really don't know. I'm not sure that you can tell. I'm happy for anyone to disagree with me or tell me what they think. I just don't quite know how to answer that question. I don't think it's an unsafe intervention. It's not like people were falling over willy-nilly when they were doing their exercises and so it's not got adverse events in that sense, but it's got a few other issues. But whether that was to do with the intervention or not, we really can't tell. I don't think we can tell. We haven't got enough information about that. So, sorry. Again, for me, I just don't know that question, the answer to that question. So that's kind of the bulk of a CASP tool. I feel that CASP is really good for what it does, but there's a lot of stuff that it doesn't capture as well. Things like the description of the intervention. So you then may need to do another checklist for that if you wanted to have a real good look at an exercise intervention and whether it's something that's replicable. I don't know if you've heard of the TIDIA checklist or the CERT checklist, but they are 2 checklists that are specific for exercise interventions in research. So if you get the tidier checklist, it'll ask you questions like, well, who's delivering the intervention? What training have they had? What qualifications do they need? Where are they delivering it? How often? How many times? What was the actual specifics of the intervention in terms of the exact exercises they were doing, dose, those kind of things are what we actually really need to know about an exercise intervention. It's all well and good saying, oh, we did it twice a week, and it doesn't tell us anything in terms of the intervention if as physios we want to go and replicate that intervention. So it's just other things like that that we need to think about.
I sometimes wonder whether word counts for journals have implications for that, and that the protocols are perhaps somewhere else. I don't know, what are your thoughts?
Absolutely, Ruth, you're absolutely right. You've got 3,000 words to write your whole research study up, and it's in, so there is lots now of opportunity for supplementary information like there was with this one. Not that they give us enough detail in that supplementary information. Some journals might actually say specifically you need to use something like the tidier checklist as well, so that you can then you actually attach that to the document and you can look and see where it's meant to be on each page. But they should now be included in supplementary information, or it should be very clear that they can direct you to the protocol and say, the description of the intervention is here. They could put it in appendices. So there is the opportunity to do it, but yes, the word count is is definitely a problem, really a big problem. But you can kind of understand why as well. They don't want reams and articles that are 20 pages long, so nobody will read it. So Charlotte?
Suzanne, could you just let us know, we just had a question there about the name of the checklist. Could you just spell it as well, please?
Yeah, Tidier, it's TIDIER. It's an acronym for something. And there's also one called CERT, CERT, that I helped out with that one. So they're well worth having a look at.
Do you think that might be something we could maybe put on our website?
Yeah, definitely. Yeah, no problem. We can do that. So, okay, right. I am conscious of time. So just going to can the results be applied to your local population in your context? I appreciate not everybody works in an acute setting, but let's just have a little look what you think. I can't answer this. This is just totally for you to tell me what you think. And by can they be applied?
I still have the screen for do the benefits of experimental intervention outweigh the harms and costs.
Oh.
That could just be me though, looking at everybody else answering there.
Can you see it now, Ruth? Or is it on you mean on your Mentimeter thing?
Yeah.
Oh. Just tell us what you say, Ruth. Yes, no, I can't tell.
Ruth, it sometimes gives you the chance to update your slide if it hasn't
I've got
moved
it.
on.
Thank you.
Yeah, real mixture, isn't it? I know that, like I say, it's not appropriate for everybody if you don't work in an acute trust, but anyone willing to share their thoughts on that? Why it is, why it's not, why you can't tell? Holly?
Hi, just more, I work in the community, but I think it's interesting more in terms of the fact that it does say about, I'm doing all hands, does say about, bring me on, I'm clapping myself, that's bad. There we go. The fact that things tail off when people come back into the community. I think so. In terms of direct application, I think a lot of people would struggle just because of the lack of detail. But in terms of if their analysis is appropriate, I think it just does show, doesn't it, that not being able to follow appropriate people up in the community and all that kind of stuff, and this lack of ability to do what I call true rehab, which is not going and seeing someone once and then once back to check their exercises and that's it. I know some people don't need lots more than that, but or just the maintenance, all that stuff that's no funding for.
Absolutely.
It So in many respects, it does have a significant kind of it shows a story.
Absolutely, and you know, it's not strong evidence, but you could use that as a business case. Look, these people who, you know, after 3 months of nothing, they've deteriorated and are coming back into hospital, and we all know that. But you've got to kind of have some evidence to show that, don't you? So
you need the funding across the board.
Absolutely.
In the hospital, and then
yes,
try and then keep that going, and it's just.
Oh, if only we ruled the world, hey. Alison, I think you were next.
Hiya, yeah. Just I think to echo what the previous speaker said, actually, because I work in community as well, and we're increasingly seeing the effects of deconditioning because somebody's been in hospital for 10 days for something medical and they haven't got out of the bed.
Yeah.
And we discovered some months ago that there was a decision not to get patients out of bed until they'd seen a therapist, but they weren't referring them to therapy. And it's like, for God's sake, guys, no wonder they, you know, and they won't let them walk to the toilet because they can't spare the nurses to take them to the toilet. So, you know, they're lucky if they manage to get out of bed and use a commode. So yeah, I think to echo the lady that spoke previously, just even if I looked at this with our new inpatient falls lead in my local hospital, just to see whether it's applicable, you know, whether we could try something that would, because she's just come into post to try and reduce the inpatient falls by X% by, you know, September of this year or something ridiculous. And you know, she's got no resources to do that with other than to try and persuade people, and it's been a very long-standing problem that isn't untypical to a lot of hospitals, no disrespect to acute colleagues. But yeah, just if there's a way that we could demonstrate the emphasis on keeping people moving and doing functional stuff while they're in hospital, and there isn't, you know, it's a bit like the what's the campaign, the Get Rid of Pajamas campaign.
Yeah, the MPJ paralysis.
MPJ, that's it. So it just, you know, to let people have a normal day of function within the limits of how well or unwell they are. Yeah. I just think it would potentially be very useful.
Absolutely. Just, I mean, I haven't worked clinically now for some years, but I was the physio on those medical wards doing that, and it's the same story. And I can't believe after 12 years of being out of clinical practice, I'm still hearing the same things that we were struggling with back then. And I know we've been through the world as it is and all the rest.
It's frightening, isn't it?
It is, and it's just such a shame.
Some things don't change.
Such a shame. Yeah, that thing about, oh, well, we can't get them out of bed till they've seen the physio. It's just like,
It's like, well, we've all done the same moving and handling training. Hello?
I know. Yeah, and again, no offence to acute colleagues. I've been there, many years.
Me too.
Sarah, sorry, you got your hand up.
Yeah, I was really just going to reinforce what Holly was saying, and I think although there are some gaps in the study that don't give us some of the detail, I think it just upholds partly what we already know, that we need to get people moving and doing more, but also this gap of proper rehab, you know, and all the money has gone into these community services for things like getting people home faster and the responsive services, but it's still left, you know, a lot of those staff then don't have the capacity or they're not even allowed the criteria to keep those people on for more than a few weeks or few sessions at a time. So I think it reinforces the need for proper rehabilitation, and that's really important. And the only other thing is I did Google your tidier, and I put a link in the chat if anyone wants to look onto it. It's by the consort, and it talks about the tidier evidence, and if anyone wants to click on that, just so they know.
Yeah, I think what I was going to say then, I've forgotten what I was going to say, but it's gone. No, it'll come to me. So I think I've just seen I've got my chat on now. So just really not clear how they adjusted for frailty, importance of patient-centered approach, what matters most, and where, there is a lot of detail missing. I think it is a single center study, and I think it feels more almost like I'm not being disrespectful to the paper, but it's almost more like an audit than a randomized controlled trial. But it's not, because it's bigger than that. But I don't know, it just feels a bit that it's lacking some of the detail of an RCT, and it's almost like a service evaluation. You know, they're trying to implement this service and seeing how it works. but they've done a little bit more than that. It's hard to know, but I think it gives us a good basis for showing that things can be done on a hospital ward. You know, it's obviously feasible, and patients were acceptive of it because they talked about the fidelity to treatment, and patients were on board with it. But it goes back to some of the chat I've seen. The staffing numbers that you need to deliver that intervention is huge, really, isn't it? You know, twice a day for 5 days a week is just unthinkable. I know that. So right, I am aware of time. Is everyone all right to hang on for another couple of minutes? Just, I know we said we'd finish at 8, but just the last question on from the CASP tool is, here we go. Would the experimental intervention provide greater value to the people in your care than any of the existing interventions? Again, not the easiest question to interpret, but do you think it would have value to your patients? I suppose an intervention, we can say an intervention like the one that they've described. Yeah, a bit of a mixture, but mainly yes. Some can't tell. That kind of rings true. Sarah DiBiase, who was our previous chair, she couldn't make it tonight, but she asked a question to me earlier. She said about the fact that the title, it's very long-winded, but it's about augmented exercise in hospital. Is that, when you read that title, did it mean anything to you? Is it something that you would have picked up and thought, oh, that might, be useful to me? Obviously, if it's not your clinical area, I can understand that. But the fact that it's augmented exercise, what if it just said exercise in hospital? Because that surely is probably more, is what it was anyway. I can't imagine them having done lots of exercise sessions. I'm just wondering what everyone's thoughts were on the title for me to feed back to Sarah. She said that was my question that she wanted answering.
I thought augmented might have been something new or different or unusual. And I know we didn't get the biggest amount of detail, but it didn't seem, obviously, we all know we want to be seeing these patients more frequently or more often, or giving them the opportunity to do more. But it wasn't anything new and dramatically different. And that's what I was kind of expected by when it's talking about augmented, whether it was through digital reminders, or I don't know what I was expecting, but that's kind of what I had in my head.
Yeah, I think they just literally mean a little bit extra, haven't they, in this instance? The augmented is a couple more sessions than you would normally get, I think, per day. Yeah, that's helpful. Thanks, Sarah. Right, nearly finished. Just a couple of one last thing. Unless, right, any other comments, questions, discussion, thoughts?
I think there's some really interesting points been raised in the chat, just talking a little bit about whose responsibility it is and to promote activity and exercise, and that really it should be that MDT collaborative responsibility rather than just fall to the therapy staff. These are often cultural things, cultural barriers, aren't they? And environment, I thought that was a really interesting point. So I know locally, a lot with COVID, a lot of the common rooms or day rooms have been repurposed to sort of nursing room spaces where they can get a lunch and stuff. And they, as far as I know, they haven't been to, gone back to the original. And I just wonder what the plans are, because I think, again, these are just further barriers along the line. But I do know that certainly locally, deconditioning is coming at us again with force in terms of avoidable harm, and this is the opportunity to piggyback on that and actually really try and demonstrate the value of what we could offer. Locally, again, one of the things that we've had some funding around some extra therapy support staff, so across OT and physio, and there's an opportunity there to explore what their added value could be. And exercise certainly could be an opportunity to illustrate that. I think, just thinking out loud.
Absolutely.
I think this study was done by qualified, but actually, while the prescription may need to be set and progressed by qualified, it doesn't necessarily need to be delivered by qualified, because they're very busy doing a lot of the assessments and discharge planning now.
Just interesting in this paper that it was delivered Monday to Friday. well, what happens at the weekend then? All that work that you've done Monday to Friday, if nobody's going to get them up and help them to walk or to move, you're just losing, I know you don't lose it, well, you do lose it quickly, but it's just a big problem, isn't it, in every way. Like I say, if we had a magic wand. Okay, just go back to the I know we didn't get this question at the beginning, but just an impression now. What are your impressions of the paper now, having kind of worked through it together? Has it changed from when you first read it? Just any words that spring to mind. We'll do a little word cloud. Yeah. Love that. Less robust popped up very big. Yeah. Vague. Yeah. Disappointing. It's always a shame when a paper's a little bit disappointing, isn't it? When you you really hope it's going to tell you all the answers. But like I say, it's hopefully a start for something that people could build on. You could use that idea to develop something yourself. Not feasible. A good attempt, yeah? Anything else? Nothing new. Okay. Which is really interesting. Yeah, we need. As a researcher, talking to you guys, it's from your people like yourselves that we need the ideas, the things that, we could really look at and try and make some difference with, to try and get a real robust trial going. So it's always worthwhile just, peeing ideas at people and kind of seeing where it can take you. Okay. Ooh, still coming. I'll get a copy of all these slides to send to everybody so we can see what we think. Okay. Any other comments, thoughts now before we just do one final question? Anyone? I know there's lots of interesting chat probably gone on. I think we should be able to get a transcript of that as well, hopefully. But so I don't keep you any longer. Let me just, if you want to, you don't have to, but just let us know how useful you found tonight's webinar. Am I pitching it at the right level? Is it not enough? Is it too fast? Is it, Holly, sorry, it's like, look at page 5 and read this. Apologies, yeah, getting carried away with myself. Yeah, all comments were, there will be a evaluation sheet will come out to you at some point as well, and then based on that you'll get a certificate of attendance, so pop that in your CPD folder. So sorry Charlotte, were you going to say that in a minute? But yeah, just great. Any thoughts? Like I say, it's meant to be a journal club where we all discuss and think and share our ideas, so I hope that comes across. Great. I shall keep looking at that. So just to finish off, done all that. Yeah, just a bit of a plug for anybody who isn't an Agile member and perhaps would like to join us. All the details are on our website. If you would want to join us, we charge £25 a year, and then you get hopefully lots of these lovely learning events and a whole lot more besides. And we have currently one vacancy on the National Executive Committee, which is the Wales Regional Rep. So if anybody's calling in from Wales tonight and would like to learn more about being on the committee, please do get in touch with either Claire or myself. But all of that information is on the website and the newsletter that we've just sent out and that kind of thing. So yeah, apologies for the blatant plug there for more people to join us. Okay, that's us done, I think. Whew. Charlotte, over to you.
So yes, thank you everyone. I found it really engaging and it was great interaction and really thought-provoking. I think we're the ones that can bring about change, and albeit in a small way, and I think it's definitely food for thought. But before we close, I just wanted to say some thank yous, really. Thank you to the Agile North Committee for organising this event. Thank you to you, Suzanne, for leading tonight's session. Thank you to the rest of the Agile Committee for supporting the event, and a special thank you to everyone who has been able to join us here tonight. And like you said, we'll be sending out an evaluation form that will generate a certificate for you on completion. I hope you all enjoyed the session and enjoy the rest of your evening. And until next time.
Yeah, and I was just going to say, if anyone has any ideas or papers or anything that they see that they'd like us to do a journal club on, please do let us know. Any topics or anything like that, just let us know, and we'll get a few more arranged if we can. Yeah. Thanks, Charlotte. Thank you everyone so much. Oh. Well done, everyone.
Well done, you, Suzanne.
Ooh, my face has gone red now.
Well done, you.
Amazing.
Yeah, that was really good. Yes, really good.
I didn't do as much kind of, not teaching, that's not the right word, more explaining of things, but I just thought I'd try and get a bit more discussion going. I'm not sure how, I can't see the chat when I'm presenting, so I've no idea what it looked like.
I really enjoyed it. I thought it went really well, and that's why I've stayed on, just to say thank you, because it was really, really good. I think it is. I was trying to watch the hands as well, which you're absolutely right, Sarah, when you said that most of it goes via the chat, and I think a lot of it is. But I think the Menti tool works really well, even though I was the one going, oh, it's not working. I thought that's really good.
Yeah.
And I think it's been a really great session, and your explanations were really, really useful.
Oh, thank you, Ruth. Thank you so much for your input and your help with it. We really appreciate it. So yeah, it's good to hear that some people, at least if somebody gets something from it, I hope that's you know, and the turnout was great again. So I think we must have found a little niche thing that people want to do, I think. So
I think absolutely. I think people are pressing that reset button and just wanting something, and they've got the sort of headspace for something, and it's just very much a refresher, I think, for a lot of people. And then it's applying that knowledge and actually thinking about the impact on your practice, potential impact on your practice, and yeah.
And I think it's good